Okay, now, I want to talk about something that's not in your handout. This is not going to be on your agenda, but I want to talk about this because it's actually quite common and a real problem. And it's a problem for psychotherapists because we do see a lot of people that have chronic pain that are coming to us because most of the time coming to us because they have severe depression. Because severe chronic pain just can destroy your life. It really severely interferes with the ability to get good sleep, but lots of different reasons. So I want to show you a few things about chronic pain that aren't in your handout, but then we'll talk about treatment with psychotropic medications. Okay, World Health Organization, cross-culturally, 15–20% of people will eventually develop chronic pain conditions, and we're talking here about significant pain, okay? And of those people, 50% of people who have very severe pain fail to recover within the first year. The longer you live with chronic pain, the worse it gets in some respects for reasons that I'm going to talk about here in just a minute. Now, there are different sources of pain. Obviously, some pain is ongoing because of the nature of the disorder. Let's say you have cancer, okay, and it's bone cancer, it's metastasized to bone. Well, you have a progressive illness, that's going to always need treatment with pain medication, okay? But there are some kinds of pain that occur where actually there can be recovery and then the pain should go away, but sometimes it doesn't go away. Now, I may have mentioned last week I broke a couple of ribs, okay? It hurts, I don't sleep well, but I know 2 weeks from now I'll be okay, all right? So what are the problems here? Now, if you look at information coming into the nervous system from the body, there are these different pathways for touch, vibration, temperature, and pain, and the term nociception is oftentimes used as a name for the pain nerves coming in, and they enter into the spinal cord, and they enter into what's called the dorsal horn, the dorsal part of, or the back part of the spine, and then they travel up the spine. They go into the thalamus, and then they go up into the sensory areas, in the parietal zone, where we register sensations, touch, feeling, so on, including pain. Now, the problem appears to be, the theory is called central sensitization, where there are pathological changes that occur in the nervous system that makes the nervous system hyper-reactive to pain. And this is interesting and scary. Okay. It looks like if you don't really control the pain adequately within the first month, the critical window is 1 to 3 months. You get beyond 3 months, and then you start or sometimes a little bit sooner, you start having these pathological changes. Now this is, again, this is scary stuff, okay. Now, what we have here is lemniscus 4 is the pathway for touch, okay, and it's separate from pain. Remember, we got these 4 different things: vibration, temperature, touch, and pain, right? And lemniscus, or pathway 2, is for pain. After several months of very intense pain, what starts getting released in the spinal cord is what we've talked about before, BDNF, which is the brain-derived neurotrophic factor, which serves all kinds of good things up in the brain, helping to rebuild the brain and repair it and so forth. But it starts causing dendrites to grow in these 2 pathways. And what starts to happen then is you start to see, instead of having separated pathways in the spinal cord, they start to infiltrate one another. And now what you've done is you have converted the touch pathway into something that delivers pain. Okay. It gets wired into the pain network, and now touch results in pain. So you go to the doctor, and somebody's had a severe shoulder injury, and it causes enormous pain, but the doctor looks at it, they get an MRI. Well, it's healed. You shouldn't be in any pain. But guess what? And people are told this all the time. Well, you shouldn't be in any pain. Excuse me, but I am. Yeah, but you shouldn't be. Anybody ever heard that story? Maybe you're drug seeking. Maybe you're just trying to get more Vicodin or what have you. And you know, occasionally that, I mean, that can happen, but in people that have this now, yeah, there's been physical recovery. You know, you don't show any measurable signs of injury, okay? But the person moves and it's excruciatingly painful. Now, one thing that's good, in some research, remember I said it goes through the thalamus? They've done brain imaging on people that have pain, chronic pain, that shouldn't be there, but they just touch them in the thalamus. The pathways from the thalamus and on up into the sensory areas light up like a Christmas tree. People are not making this up. And insult to injury, I mean literally to injury, is when people start being treated as if they're hypochondriacs or they're drug seekers or they're just depressed or something like that. Their pain is not validated, and then they feel, you know, misunderstood and mistreated by the medical profession. Yes.
Okay, question.
Yeah.
And I don't know if there's an answer to this, but how do you differentiate this from, because I've also heard that in people who are abusers of pain, opiate pain medication, that the brain starts to essentially make up pain because it's that like addiction cycle, you know, of there's still pain, so they still need medicine, that whole thing. How do you
Right.
differentiate those two things, or can you?
See, I don't know that you can differentiate those, okay? I just don't know. But what I'm going to be talking about is preventing this from happening and treatment for it, okay? But, you know, I'm not a pain expert, and also I think the jury is out on that. And, you know, dogs can have fleas and ticks. I mean, right? You get people that have bona fide pain, and also they kind of like your OxyContin, too, at the same time. Okay, so that's one thing. The second thing is failure of top-down control that we've talked about here before. And this is so interesting here. If you look at the pain pathways, okay, it goes through the spinal cord, okay, but eventually, in addition to going to the cortex and the somatosensory areas, it goes into the anterior cingulate. Now, there was this guy, this was many years ago, I can't remember his name, it was maybe 25 years ago. This was a guy at UC Davis, a psychologist, and there were people that were completely intolerant of general anesthesias, okay? They would have extraordinarily severe allergic reactions, what have you. And this guy would hypnotize people, and then they could do, like, abdominal surgery, and they wouldn't feel any pain. It's just like, what? Yeah, that just doesn't seem right. Holy mackerel. I mean, this person is there, and they're cutting their stomach open. They're doing open heart surgery. Well, it looks like what happens is it's possible for parts of the frontal lobe, here the anterior cingulate, to exert significant top-down control that blocks pain as it's coming into the spinal cord. And activating this can be achieved, at least with some subjects, by the use of hypnosis. There also, you know, are numerous anecdotal reports of people who are in these deep meditative states, you know, they can walk on hot coals and not feel the pain. Everybody's heard about that kind of stuff. Okay, so what is going on here? Well, excuse me. Serotonin and norepinephrine turn out to be two neurotransmitters, not in the brain right now, although it's initiated in the brain. The frontal lobes are activating this, going down to, and then turning on the release of serotonin and norepinephrine at the level of the spinal cord, and they interact with endorphins to block pain. Now, what's been found is that if you treat with antidepressant medications that target serotonin and norepinephrine, not in everybody, but in many people, there is significant control over pain. Drugs that only treat SSRIs don't work. Those that only increase norepinephrine don't work. You've got to use agents that do both. All right. So, a couple of tricyclic antidepressants that have been around for, you know, decades are used. And actually, if you look at all of these drugs, it turns out that the one that is probably the best is Elavil, okay? Amitriptyline, this old generation tricyclic antidepressant. And if people don't have clinical depression, but they've got very severe chronic pain, you can get by using very small doses of Elavil. And when I say for treating depression, you have to use at least 150, 200 milligrams. Okay. Here, some people respond to 10 milligrams. Probably most people require 25 to 50 milligrams. Okay. It's not here. We're not talking about treating depression. We're talking about pain control. Okay.
What was the dosage you said?
Well, probably the low end would be 10 milligrams. Most people, it's going to be 25 to 50. All right. And then these drugs are also dual action, selective serotonin and norepinephrine reuptake inhibitors. Okay. In fact, Cymbalta is FDA approved for treating chronic pain as well as depression. Now, here's the point that I want to make 2 points. Okay. Point number one is a lot of people with chronic pain also develop depression. Okay. So you can kind of kill 2 birds with 1 stone if you pick the right medication. But the second thing, and clinically this is really, really important, is that lots of people who've suffered for months, but especially for years with chronic pain, have gone from doctor to doctor. And they're either told there's nothing else I can do for you, or they're told, you know, you're into drug seeking, or they're told this is a psychological problem, or you're depressed, or what have you. And then they go to somebody and they get, you know, they get a prescription for Cymbalta or for Elavil or something, and then they go home, get on the internet, and it's like, this is an antidepressant. And I'm not making this up. This is not uncommon. They go, here we go again. This doctor didn't tell me it was an antidepressant, you know, here we go again, somebody thinking I'm crazy, it's all in my head, it's just psychological, and then they don't take the medication. Okay, so, you know, here we have to really educate patients that they may have depression, they may not, but the real intention here is to actually increase norepinephrine and serotonin at the level of the spinal cord. And these drugs are not habit-forming like opiates. Okay, and for many, many people, they can be very helpful. They can also be given along with other pain medications as well. Okay?
What's the time frame from when, if someone is going to respond to that for pain, what's the time frame?
Okay, it's good question, and it can be within a couple of days to several weeks. And the thing that really makes the difference here is you can't tell from the get-go what the dosing is going to be because people metabolize drugs in different ways. And so I would say if somebody were very sensitive to drugs in general, or they had problems, like Elavil causes constipation, for instance, and causes dry mouth and stuff like that. It can cause confusion at times in older people. So you have to take their medical status into consideration to choose the drug. But then you have to go in and play with the dose. So it may take a while to find out what dose is most effective. But it's possible that within a few days or a week, some people are going to start experiencing, because guess what? Reuptake begins when? A couple of hours after you start taking the medication. So we're not looking at the time frame that you ordinarily would be looking at for treating depression. Okay. And this is yet another thing, it's not in your handout, but in depression, one thing that happens is it causes the immune system to secrete what are called cytokines. Cytokines are the messenger molecules of the immune system, okay? And with depression, even though you're not sick, physically sick, you don't have an infection or something, there are increased levels of what are called pro-inflammatory cytokines. Inflammation plays a role. When people have injuries and so forth and burns, there's an appropriate role for this, but if you have chronic inflammation, that can cause pain in itself or can exaggerate pain. And what antidepressants do is it reduces the levels of pro-inflammatory cytokines. And so this, nobody knew this when they developed antidepressants. It's one of those things they discovered by happen chance, but that's good. It's good news. So we have really a couple mechanisms of action here that account for the analgesic effect of antidepressants. Now, it looks, I mentioned before, it looks like a critical window is 30 to 100 days, and this came out in a statement put out by the American Society of Pain Education at the end of 2009, and basically what they say is they say we need to avoid this rewiring in the spinal cord, which means we've got a month to maybe 3 months to pull out all the stops. And what's done too seldom is to do a multimodal treatment, integrative treatment. Usually people are just given pain medicine and say, well, hopefully this will help and you'll heal. But what they say, when indicated, we need to aggressively treat depression if depression is a part of what's going on. Secondly, if medically indicated, get physical therapy, okay? If medically indicated, exercise, and also do very aggressive pain management, okay? Especially in this early stages, let's try to get this under control. So it means not just writing a prescription, but utilizing physical therapists and getting people to exercise and that kind of stuff. It just simply increases the chances, that there will be some resolution of chronic pain before the spinal cord basically starts rewiring itself. Now, BDNF is what's causing the abnormalities in the spinal cord, and so there are experimental drugs where they would inject BDNF into the spinal cord. And the thing is, you wouldn't want to block BDNF, by taking a pill, because it's necessary in the brain, obviously, for protecting the brain. But that's entirely experimental. Okay. And actually, I think this is the one that's in your handout. And among psychiatric medications, Neurontin is very good for neuropathic pain, nerve damage, from spinal cord injuries. Many people have diabetes, develop peripheral neuropathy, damage to nerve cells. Some people have chronic severe alcoholism, have peripheral neuropathy. So, and Neurontin is used to treat seizures, and it reduces the firing of nerve cells. Well, guess what? It also reduces the firing of pain nerve cells as well.